Hi, my name is Christina U, and I'll be doing a presentation on decreasing patient falls in the hospital. So, my chosen theory is the Lewin's change theory. So, Lewin's change theory encompasses the stages unfreezing, change, and refreezing, which can be pivotal in reducing patient falls during night times in hospitals. Unfreezing involves recognizing the issues and the need for change, which is acknowledging the high incidence of night falls. During the change phase, interventions like improving lighting, bedside alarms, or regular monitoring can be implemented. Refreezing solidifies these changes into daily practices, ensuring they become the new norm. By systemically assessing the issue and applying these stages, healthcare settings can achieve meaningful, sustainable reductions in nighttime patient falls. So, problem identification. So, nighttime patient falls in hospitals are a significant concern as they decrease patient safety and leading to injuries. Beyond the financial implications, there are other considerable non-monetary repercussions. Hospital reputations may suffer due to such incidents, leading to decreased trust from patients. On the staff side, witnessing or being involved indirectly with these falls can cause emotional distress, often diminishing job satisfaction. Furthermore, the inevitable investigations that follow such incidences divert essential resources away from the patient care, impacting the hospital's overall efficiency and focus. Bearing the statistics above in mind, it is prudent to address the issue of patient falls by incorporating a plan to change practice. Notably, interventions such as bedside alarms have been utilized to decrease patient falls during nighttime, but the cases are yet to drop, significantly enhancing a proposal to enhance documentation of patient falls. So, the significance of the problem. So, generally, falls in the hospital setting brings about challenges such as decreased patient safety, a patient reduced efficiency, and cost effectiveness of healthcare services. Notably, more than 9,000 falls occur in the U.S. annually. Consequently, patients' fall translates into increased lengths of stay in the hospitals, thus increase in costs incurred by patients and healthcare facilities as well as dissatisfaction. Further, Medicare and Medicaid services have benchmarked for compensation of hospitals, and when falls occur beyond the expected benchmark of over 3.35 patients' days, there are no compensation. It is therefore prudent to look into the interventions that would decrease and manage the occurrence of patient falls during night shift. So, my EBP project question. So, the population, hospitalized non compliant patients are chosen because they present a higher risk for falls due to factors such as cognitive impairment, mobility issues, refusal to follow safety instructions, or inability to understand their risk. The chosen intervention will be rigorous bedside safety measures, including alarm systems and family engagement, which is based on evidence that suggests these methods can significantly reduce the risk of patient falls. Bed alarms can alert staff when a patient attempts to get out of bed, allowing for a timely intervention. Family engagement is also a proven strategy as family members can help orient the patient, assist with mobility, and provide comfort and supervision. The comparison is the standard care. It refers to the current practice of all fall prevention, which might not include the proposed intervention. It is essential to compare the proposed interventions against standard care to quantify their effectiveness. So now the outcome. The outcome is the incidence of falls during the night shift. It is chosen because falls are a primary concern for patient safety, and the rate of falls is an objective measure of the problem. Night shifts are highlighted because falls often increase during this time due to lower staffing, patient disorientation, and changes in patient sleep patterns. The time, which is the course of 1 month, is selected as an appropriate duration to observe changes in fall rates without being overly lengthy or too short to see effects. So my review of the literature, the identification of databases were PubMed, CinNow, Cochrane, and Google Scholar. The keywords that I used were hospital falls, night shift, fall prevention strategies, patient compliance, patient care, and bedside safety measures. So, potential for success of planned change. To reduce falls in noncompliant patients, urgent interventions like rapid bed alarm responses, enhanced monitoring, and family presence are essential. Yet falls persist. Gowling showed that documenting falls reduced their occurrence. A finding supported by McCarthy emphasizes electronic documentation. Fall prevention interventions in healthcare settings stand as one of the most promising strategies to ensure patient safety. When meticulously executed, these interventions they have the potential to drastically reduce the frequency of falls, thereby mitigating the associated risk of injury, prolonged hospital stays, and increased medical costs. By targeting known risk factors such as environmental hazards and medication side effects, and bolstering staff training and awareness, these measures can create an environment where falls become rare occurrences rather than common events. The ripple effects of successful fall prevention are profound, spanning improved patient trust and enhanced facility reputation, and a notable decrease in litigation risk associated with fall related injuries. Moreover, the psychological and emotional well being of patients is preserved, as they are spared from the trauma and potential disability of a fall. In its essence, the success of a fall prevention intervention is not just measured in numbers, but in the overall upliftment of patient care quality and the fostering of a safety first culture. So, factors that enhance the achievement of fall prevention strategies: structures, reported systems, and standardized data capture ensuring accuracy. Training and awareness emphasize the importance of meticulous fall documentation, promoting consistent reporting. A collaborative approach involves all healthcare stakeholders and patients and families, ensuring comprehensive insights and holistic solutions to fall events. Continuous hourly routing also avoids patients from getting out of bed. Together, they significantly enhance fall documentation quality and effectiveness. So, factors that undermine achieving effective fall prevention. Time constraints and fast paced hospitals can impede thorough documentation. Underreporting, driven by fears of repercussions, masks the true incidences of falls. And lack of standardization results in an inconsistent data capture, leading to fragmented insight. These factors collectively compromise the quality and effectiveness of fall documentation in hospitals. So, plan of action and recommended practice. The action plan for prevention during the night shift integrates several evidence based strategies to ensure patient safety. A nightly huddle is essential, where the night shift team comes together to discuss high risk patients and anticipates their needs. Environmental check plays a pivotal role in this plan, ensuring clutter free pathways to mitigate tripping hazards. In addition, the implementation of scheduled toileting has been demonstrated to significantly reduce nighttime falls, addressing a primarily reason patients might attempt to leave their bed unassisted, according to Goldsberg. Alarms and sensors have proven to be instrumental tools, especially when maintained properly, as they alert staff to potential falls in real time. Moreover, to refine and adapt our approach, a brief morning debrief is conducted after every shift. This session offers invaluable insights, allowing the team to make necessary adjustments to the prevention strategies, ensuring they remain effective and responsive to patient needs. Policy and protocol for practice change. The consistent theme in literature review: inadequacies in fall documentation. The policy, therefore, will seek to decrease patient falls during night shift by promoting the adoption of electronic documentation as means to decrease administrative practices such as charting patient health information and increasing time for bedside care. So, one, of course, enhancing fall documentation among nurses, structured reporting systems and checklists, training and awareness, collaborative approach, and hourly rounding. Consequences of the proposed strategies. So, proper documentation upholds accountability, informs future care strategies, and provides legal protection. Yet, it can be time consuming, raising privacy issues, and may sometimes lack complete transparency due to concerns of potential repercussions. Each approach to fall prevention offers distinct advantages and challenges. Risk assessments and communication can lead to targeted healthcare strategies, ensuring that care teams are well informed and that patients and families are educated and involved. However, this can sometimes result in excessive mobility, restrictions, or unintentional stigmatizations of high risk patients. Environmental adaptations ensure safer patient navigation and independence, but might inadvertently cause over reliance on staff and can be financially depending for healthcare settings. So, documentation as a preferred approach to fall prevention during night shift. According to a study conducted by Gallen, patient fall decreased to 2.47% patient days against 3.44 patient days, which is the national benchmark when fall documentation was incorporated, hence a more preferred approach. Further, in support of Gallant's findings, a separate study conducted by McCarthy encouraged adopting electronic documentation as a means to minimizing and preventing patient falls among hospital-acquired injuries. So, our expected outcomes after implementing fall documentation. Implementing comprehensive fall documentation in healthcare settings yield multifaceted benefits. A primary outcome is a notable reduction in fall incidents resulting from the ability to identify and rectify prevalent risk factors. This robust system elevates patient safety and emphasizes the need for proactive measures. The consistent recording not only streamlines communication among healthcare professionals, but also fosters enhanced staff awareness, ensuring cohesive patient care. Such structured documentation enables data driven decisions, promoting effective resources allocation, and refining staff training based on real scenarios. Increased accountability emerges as staff meticulously record observations and interventions. Moreover, this documentation serves as a dual purpose. It offers a legal protection by showcasing the facility's efforts in managing falls and bolsters patient trust as they perceive the facility's commitment to safety. Ultimately, fall documentation acts as a catalyst for continuous quality improvement, underpinning the drive towards excellence in patient care. So operationing fall documentation. So ensuring patient safety in hospitals during night shift demands specialized strategies to prevent and document falls. Night staff confronted with challenges like medication-induced patient behaviors change and dim lighting requires shift-specific training to aptly recognize risk. Continuous education through workshops can further hone their skills in fall prevention and documentation. Utilizing standardized documentation tools such as electronic health records guarantees that fall incidences are consistently recorded, while checklists provide a comprehensive outline for capturing all vital details of the event. Environmental measures, such as including adequate lighting and nighttime surveillance systems like motion sensors, can proactively deter potential falls, according to Cho. Implementation of fall documentation. So effective communication remains paramount with structured handover protocols, ensuring and incidents are swiftly relied to subsequent shifts. In addition, a real-time reporting mechanism allows for immediate responses, mitigating these potential post-fall complications, as previously mentioned. So to implement a fall documentation intervention, one must first train staff on recognizing fall risk and proper documentation techniques. Standardized tools like electronic health records should be utilized for consistency. Environmental adjustments such as adequate lighting, coupled with real-time reporting mechanisms, ensure immediate actions. Periodic reviews, technological aids, and feedback further refine the system, ensuring both patient safety and effective documentation, according to Johnson. So, evaluation. The primary goal of the evaluation plan is to determine the efficiency of the fall checklist documentation strategy in mitigating patient falls. This involving setting clear objectives such as gauging the decrease in fall rates, appraising staff adherence to documentation protocols, and pinpointing potential enhancements. Data collection is pivotal, encompassing fall incident reports for pre and post implementation comparison, compliant checklists, and staff surveys to discern their views on the system's efficiency. Key performances indicators, including all fall rate documentation, precision, and staff contentment, offer measurable metrics of success. A thorough analysis of this data can reveal impactful insights, patterns in fall occurrences, and correlations between precise documentation and fall reductions, and the general effectiveness of the strategy. Feedback from the staff and quality improvement teams further enriches the evaluation, leading to continuous refinement of the strategy through targeted recommendations, extended training, and procedural tweaks. The culmination of this process is a detailed report integrating visual data aids and accountable insights to chart the path forward for optimizing fall documentation and ensuring patient safety. These are my references. Thank you.